thought to begin with, we'll do sort of a sweep and a prior knowledge check to see how people are doing. I know you guys are third years mostly, so you should have a pretty good basic knowledge, but let's have a look. So I hope you all know this heart. And if we start from the blood supply coming into the heart, so we've got the superior vena cava and the inferior vena cava coming in to the right atrium, flowing through the tricuspid valve into the right ventricle. Then the right ventricle contracts and the blood travels up through the pulmonary valve into the pulmonary veins. Now, I found this a bit confusing when I was a med student because you normally think veins travel towards the heart. But in this case, pulmonary veins are traveling out of the heart towards the lungs. And then the blood gets oxygenated. So oxygenated blood comes back from the lungs into the heart through those pulmonary arteries that are unlabeled, but you can see on the back, into the left atrium, pass through the mitral valve, probably the most important valve, I'd say, into the left ventricle, where it's then pumped up, back through the aortic valves and into the aorta to spread around the body. Now, I'm pretty sure you all know the basics of that, how the blood flows through the heart. But a few more questions about the basic structure. What are the 3 layers of the heart? Can we get any answers on the chat? Come on, people. Let's give it a go. No? All right. I've got the answers for you, don't worry. We have the pericardium, the myocardium, and the endocardium. And that's starting from out inwards. So if you look at this picture, the pericardium is that lining, the white lining. It's usually quite fibrous, quite thick, and is protecting the heart. Then you've got the myocardium, which is that muscular layer, and the endocardium, which is lining the inside chambers. So pericardium, myocardium, and endocardium. Next question is a little bit more clinical. Where would you auscultate to listen to the aortic valve and the mitral valve? These are probably in clinical practice the valves that you can hear the easiest and are usually indicative of the most common pathologies. Any answers? No. Oh, Safia. So aortic valve, second intercostal space on the right. That's very good. And Abdullah is saying mitral valve. Yeah, where would you listen to the mitral valve? So here's a little picture for you. Aortic valve, as Safia said, is the second intercostal space, right sternal edge. And then, as Sophia also said, mitral valve is the 5th intercostal space, mid-clavicular line. Exactly. And that 5th intercostal space, mid-clavicular line, is where you would feel for the apex beat when you're doing a cardiac examination. So remember that 5th intercostal space, mid-clavicular line. That's a typo there. It should be 5th, not 2nd. Is where you feel for the apex beat and listen to the mitral valve. Okay, which vessel carries deoxygenated blood to the lungs? We've got a picture right there, so that's not very hard, guys. It's your pulmonary veins carrying deoxygenated blood to the lungs, where it gets oxygenated and comes back. All right. So now let's talk about the anatomy of our valves. We've got this view, which is looking from above the heart, looking down onto each of the chambers and the associated valves. The first one that I'd like to speak about is the mitral valve. And as we said earlier, that connects the left atrium and the left ventricle. And I'd say the left side of the heart carrying oxygenated blood is probably more important. Controversial opinion, arguable, but the mitral valve carrying that blood passing through it is quite important, and you get a lot of pathology of the mitral valve affecting a lot of the elderly population, but we'll get into that in a bit. And it's bicuspid, importantly. It's the only valve of the heart that is bicuspid. The rest of them, as you can see, are tricuspid. Then we've got the aortic valve, also in the left, on the left side of the heart, that's carrying, or blood passes through it from the left ventricle into the aorta, and it's tricuspid. Then we've got the tricuspid valve between the right atrium and the ventricle, also tricuspid, as the name would suggest. And then the pulmonary valve between the right ventricle and pulmonary trunk, which is tricuspid. And now, as a medical student, I remember finding valvular pathology really difficult to remember, especially the different types of murmurs you'll hear. But I think one tip I can give you guys is really focus mostly on your mitral valve and your aortic valve. So the left-sided valves, because they're the ones you're going to hear them better. B, exam questions mostly focus on them. And C, they usually have more of an effect on your patients than the other two. Because if you think about it, it's your oxygenated blood that's really important to get out and around the body. So if these valves are affected, you're going to have worse outcomes. So really focus on your mitral and your aortic valves when it comes to revising. And we will go into the pathologies as well. Oh, don't worry. I thought first, let's briefly go through the flow of blood and the difference between diastole and systole. So blood first comes into the atrium by a passive filling. So your valves here are closed. The valves that are between your atria and your ventricles are closed. And blood pressure is allowing those atria to fill. And then those AV valves open and the blood's still flowing through your ventricles into the heart. And this is diastole. So when your heart is essentially filling up with blood, there's a slight atrial contraction, but there's no fully forced ventricular contraction. So it's passive. It's diastole, filling up of the heart. Then we have the closure of the AV valves, which is what your first heart sound is. And then we've got the ventricular contraction, which is probably the most important part of the heart's function. So those semilunar valves, which are your aortic and pulmonary valves, open up nicely, your ventricles contract, and your blood comes out. That's systole. And when your aortic and pulmonary valves close is when you have your second heart sound. So the first heart sound is your mitral valve and your tricuspid, allowing blood to stay in the ventricles. And then the second heart sound is when the aortic and pulmonary valves close. So the closure of which valves produces the second heart sound? We've just spoken about it. Great. So A Very good. Any other answers? A and C, exactly, Anjali. Very good. A and C are creating the second heart sound. So we've got a nice diagram here showing that S1 is the closure of your mitral and tricuspid valve. And then systole occurs, which is when the ventricles contract and get the blood out of the aorta and the pulmonary arteries. Then we that's when you can feel a pulse. That's when your pulse is palpable. And then S2 is the closure. And that's when the heart refills again passively through diastole. All right. So now, as promised, don't get too excited. We're going to talk about valvular pathology. And as mentioned earlier, the two most important are your aortic and mitral valves. So those are the ones we're going to talk specifically about. Firstly, aortic stenosis. I'd say this is the most common valvular pathology you will see. And quite a few of our elderly patients have aortic stenosis murmurs that you can hear. So once you guys become an F1, this is actually quite a common presentation. What causes aortic stenosis is old age, essentially, when your valve becomes calcified and undergoes general degeneration, you can have aortic stenosis, which is, so stenosis, I'm sure you all know, is just sort of narrowing of the valve. It becomes really tight and doesn't allow blood to flow through it as nicely. And as a consequence, you get a triad of symptoms. So if your blood isn't able to come out of the ventricle into the aorta, you can get chest pain, you can get dyspnea, which is breathlessness, and syncope. So if you're not getting enough blood to the body in specific up to the brain, syncope can occur. So I have had patients who've come in and say, oh, I was just walking, I had a bit of chest pain, and then I fainted and I'm not sure what happened, and they are otherwise medically fit. And you'd initially think, oh, is it a blood pressure problem? Well, actually, you listen to their heart and you can hear a bit of a murmur, and you've got your answer. So what sort of murmur would you hear with aortic stenosis? Does anybody know? Ejection systolic. Really good, Anjali, well done. So an ejection systolic murmur, which is, unfortunately, I don't have recordings, but it's basically a whooshing sound, and it sounds a bit like a train when you listen to it. And so it's like whoosh, doop, whoosh, doop. That was my imitation. So a whoosh, a whooshing sound, sort of like a train, as I said. Secondly, we've got mitral regurg, which is the second most common valvular pathology. And it's where, as the diagram shows, it's where the blood coming from the left ventricle going up into the aorta is instead regurgitating up into the left atrium. So your blood is meant to be going up this way, but instead a little bit of it is backflowing into the left atrium. So it's not great, again, for your blood circulation around the body, because a lot of it is actually not getting out through the aorta and backflowing up. So the causes of mitral regurg most commonly is post-MI. So if there's an infarct somewhere along this side of the heart, you can affect the valves, especially if your papillary muscles are affected. Rheumatic fever is another very common cause of several valvular pathologies, usually in younger patients. So if you've got sort of like a 40-year-old woman, women are exceptionally or more prone to getting rheumatic fever and valvular pathologies than men are. Think mitral regurg. Endocarditis is also a cause of mitral regurg and also a cause of the others as well. So if anybody asks the cause of a mitral stenosis or regurg, I'd say my top differentials are always rheumatic fever or endocarditis. And what sounds would you hear? It's a soft S1 and a pan-systolic murmur flowing. And if you think about it logically, actually, you can sort of answer these questions yourself, because the closure of the mitral valve is what causes S1. So if your mitral valve is screwed up and not closing properly, you're going to get a soft S1, aren't you? And that's what causes the regurg, is when your valve isn't closed properly. So it's not shutting, it's not causing that loud S1. Instead, it's soft. And then you get a pan-systolic murmur. That's because when the ventricles contract, so when systole occurs, that blood is sort of just bubbling up. So it's throughout the whole systole. So it's bubble, 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 whilst the ventricles are contracting. Then we've got mitral stenosis, which, as I said earlier, rheumatic fever, rheumatic fever, rheumatic fever. Mitral stenosis, the cause, if you've got other options, rule them out. It's rheumatic fever for the case of med school exams and MCQs. What would you hear with mitral stenosis? Anybody know? So again, we can sort of conclude from the pathology. If you've got a really hard, tight valve, when it closes, it's going to make a loud sound because it's sort of hard and cracky and narrow. So you're going to actually get a loud, hard S1. So when systole happens, it creates this hard S1 sound. And a mid-diastolic murmur, again, we can sort of conclude that by going over how blood flows. So when diastole occurs is when blood is flowing through the mitral valve. All right, then we've got aortic regurg, which is I'd say probably as common as mitral stenosis in clinical presentations. So aortic stenosis, the most common, mitral regurg, and then mitral stenosis and aortic regurg come along. What are the causes? So rheumatic fever is one of them, but also connective tissue diseases, such as Marfan's, can cause your valves to be a bit funny and cause aortic regurg, as well as mitral stenosis, but not as commonly. Endocarditis as well, as mentioned earlier, where bacteria can sit on the valves and cause them to not function as properly. What would you hear in an aortic regurg? Any thoughts? Any answers? So an early diastolic murmur. So, sort of giving this away a little bit earlier, but a 77-year-old man is admitted to A&E after he fell down in the park. He reports he was taking his dog for a walk this morning and felt a crushing pain in the center of his chest when walking up a hill. He recounted feeling breathless, dizzy, and then lost consciousness. His ECG showed ischemic changes. On examination, a loud ejection systolic. Sorry, his ECG showed no ischemic changes. On examination, a loud ejection systolic murmur was heard. Given the patient's history, which valvular pathology do you think he has? D, aortic stenosis. Zara, correct. I gave this away a little earlier, but well done. This is a very common question and a very common clinical scenario. So I would definitely memorize aortic stenosis is a loud ejection systolic murmur, and the triad of symptoms are angina, dyspnea, and syncope. Okay, we've got another question. So a 39-year-old woman recently returning from Chad is admitted to A&E with a high-grade pyrexia. She reports a week-long history of joint pain and has been feeling more and more breathless since her flight. On examination, she looks a bit overloaded and you can't hear the first heart sound. A pan-systolic murmur is heard, which radiates to the axilla. Given patient history, which valvular pathology do you think she has? B. Safia says B. Any others for any others? Very good. So Safia, exactly. I think in this case, I was hoping there'd be a little bit of confusion and I'd hoped I'd trick you out on it, but actually you got it right. So Safia, well done to you. I did think some people might question whether it's mitral stenosis because as I said earlier, rheumatic fever causes mitral stenosis. But then a pan-systolic murmur with a soft S1 would actually be mitral regurg. Well done. Okay, so now moving on to blood supply of the heart. Again, I've got a couple questions here. Try and answer them if you can, and if not, we've got the labels. Which are the two main vessels supplying the heart? Any answers, guys? Two main blood vessels. Really good, yeah. Right and left coronary arteries, exactly. So you've got your left on this side, coming straight off the ascending aorta, and the right on the other side. And then what are the two main branches of the left coronary artery, and what parts do they supply? Safi is answering all the questions. Come on, guys. Left anterior descending and left circumflex. Really, really good. Yeah. So circumflex comes around the back and goes more lateral towards the other side of the heart. And the left anterior descending comes down nicely to supply not only the left atrium, but also the left ventricle, and then a bit of the apex as well. Really good. Now, what are the two branches of the right coronary artery and what parts do they supply? This is a bit more of a difficult question because I feel like these arteries aren't really spoken of a lot. The right coronary artery branches into the right marginal, which comes down and supplies the right ventricle. But also we have the posterior descending artery. And now if you can see round the back here, it comes and supplies the posterior aspects of the right side of the heart. And then, as Safia's very correctly said, the right coronary artery is what supplies the AV node and the sinoatrial node. So now, logically, moving on to myocardial infarctions, which is when you have a blockage of one of the coronary arteries. And as I'm sure you all know, we've got two types of MIs. So firstly, we've got our NSTEMIs, which are not as bad because they're not fully occlusive. So as you can see in this diagram, usually the thrombus or the atherosclerosis isn't entirely blocking the artery. So the heart is still getting a little bit of blood flow, just not as much as it needs. And an NSTEMI, which stands for non-ST elevation MI, has no ECG changes. Whereas a STEMI, that stands for ST elevation MI, does have ECG changes, and it's usually fully occlusive. So I know this diagram shows that there's still a little bit of an opening, but that blood is just not enough. So a STEMI, for all intents and purposes, is a full occlusion of that artery. And the treatment of an NSTEMI is bromance. I hope you all have heard of this mnemonic. Bromance stands for a beta blocker, some reassurance is the R, oxygen, morphine, aspirin, nitrates, clopidogrel, and enoxaparin. So these are all medications that you essentially give for an NSTEMI, and then there's not really any other intervention required. Whereas for a STEMI, which is a lot more serious, your treatment's going to be MONA, which is morphine, oxygen, nitrates, like your GTN spray, and aspirin or cloppy, considering where you are, dual as well, sometimes, and PCI. So a STEMI will always, always, always need to go through the cardiologists and straight to the cath lab for a PCI. All right. I'm sorry, I'm whizzing through that just because I'm wary of time. So, next question. A 61-year-old man presents to ED with central crushing pain, chest pain, which radiates into the jaw and is associated with nausea and profuse sweating. You perform an ECG, which shows ST segment elevation in leads 2 to 4. You diagnose an anteroseptal ST elevation MI. Anteroseptal. Which coronary vessel runs along the interventricular septum on the anterior surface of the heart to reach the apex? So in other words, which artery do you think is blocked in this scenario? C, exactly, Safia, very good. Your left anterior descending artery, which is actually the most common artery that gets blocked in MIs. So if in doubt, always say your LAD. Now, just a little bit of discussion on the great vessels and levels of bifurcation. Now, this is kind of dull, I know. I apologize, and there's no real way to help you learn this. This is just, you're going to have to memorize it. But first, easily, we have the branches of the arch, which are the Brachiocephalic, which then splits into your right common carotid and your right subclavian. We've got your left common carotid and your left subclavian. So your left common carotid and your left subclavian come straight off the aorta, whereas on the right side, they come off the brachiocephalic artery. Then coming down the descending aorta, we've got our celiac trunk at level T12. So try and remember these as we go along, guys, because I've got a couple questions to really solidify it afterwards. Celiac trunk, T12. Then we've got superior mesenteric at L1 at this level here. And that supplies the proximal bit of your gut. Then we have the renal and testicular coming off at L2, just one level lower. Then we have your inferior mesenteric coming off at L3, and that supplies the distal aspect of your gut. Then we have the bifurcation at L4, where the aorta bifurcates into your common iliacs. And then your common iliacs, left and right, split into your internal and external iliacs at L5. So that's your tiny little internal at L5. So take a look at these levels again, and I've got a few questions for us. A gentleman presents to the emergency department with symptoms of a stroke. A CT angiogram is performed, which shows a narrowing of the artery supplying the right common carotid. Which artery has been affected? Exactly. It's number E, not number, letter E, brachiocephalic artery. So on the right side, as I said earlier, on the right side of the aortic arch, you have your brachiocephalic, then splitting into your right common carotid and your right subclavian. Whereas on the left, they come straight off the aorta. Now, a 67-year-old man presents to ED with severe central abdominal pain radiating to the back. His records reveal a past medical history of an abdominal aortic aneurysm. A focused abdominal ultrasound test reveals diffuse dilatation of the abdominal aorta, most prominent at the site of its bifurcation. Which one of the following vertebral levels correspond to the site of the most prominent dilatation as evident by the FAST scan? So what level does the aorta bifurcate into your common iliacs? Come on, guys. This is quite important. This is the one level you should remember. Zara, exactly, L4. So L4 is where your aorta bifurcates. And actually, one thing that really surprised me was how high up L4 actually is. So if we go back to that diagram here, L4, the common iliac bifurcation, if you look on this side, actually, it's commonly in line with your belly button. And I know it looks further down, but in patients, your aorta actually bifurcates quite high up. L4 is higher than you think. All right, now comes the tricky bit. Conduction pathways of the heart. So I thought we'd go through the conduction pathway and then onto ECGs. So what are the two nodes of the heart and where are they situated? I think we already kind of briefly answered this. We've got the sinoatrial node, which sits in the right atrium, right by the superior vena cava opening. So quite superiorly. And then we've got the atrioventricular node, which sits in the interatrial septum. So it sort of divides both atria, but also the atria and the ventricles of the right side particularly. What does the bundle of His split into? So the conduction comes from the SA node to the AV node and then passes down into the bundle of His, which splits then into your left bundle branch and your right bundle branch. So 3 is your left and 4 is your right. And I've done it 3 and 4 because actually it's your left side that the signal runs first through. So from the AV node coming to the bundle of His, splitting into left and right. And first it goes down the left side. And that's quite important when you talk about ECGs and left bundle branch block versus right bundle branch block. So coming down the septum, it always comes from the left side first. And then what does your left bundle branch split into? This is a more niche question. Anybody? So it's your fascicles. Anybody know what the name of the fascicles are? So we've got your anterior and posterior fascicles. And in ECGs and the heart block, if you've ever heard of trifascicular block, this is what it means. So it's affecting your left bundle, which is made of your anterior and posterior fascicles, as well as your right bundle. So in total, the 3 bundles, 3 fascicles. And then, as I'm sure you all know, what helps distribute the signal through the ventricles? So coming down the bundle of his and then through the ventricles. What are they called? Starts with a P. Nope. It's your Purkinje fibers. So they're the ones that distribute the signal up through the walls of the heart. All right. Now onto ECGs. This is what a normal ECG will look like, the waveforms. The first upward deflection is always a P wave. Then we've got the first downward deflection is your Q wave. And the reason why I'm saying it like this is because sometimes you can get a second, it will look like a second wave, but actually instead of a double P, it will be an R. So the second upward deflection is an R wave. Coming down, the second downward is an S. And then you have this ST segment, which should always be flat, coming to your third upward wave, which is a T wave. And sometimes you get a U wave over here after T, but that's not very commonly seen because it's so small. So if we think about what's happening in the heart during these waveforms, P is atrial depolarization in response to the SA node triggering. So your SA node triggers the atria, and they become depolarized, which is why you get this spike in the voltage. And then your QRS, so the PR here, the flat line of after a P wave, is because your SA node takes a little bit of time for the signal to come through to the AV node. And that delay is what this PR line is. So if you've got a large delay, your PR complex is going to be elongated. Then we've got the QRS complex, which is the most sort of recognized form of an ECG, that upward spike, which is your ventricular depolarization. So when your ventricles get the signal, they depolarize and contract. So that's the main pumping contraction. That spike is when your ventricles are contracting and the blood's coming out. Then we have your ST segment, which is the beginning of when the ventricles relax again. So the signal stopped, your ECG is flat, there's no electrical activity. And then we have the T wave, which is ventricular repolarization. So when your ventricles have relaxed and aren't contracting any further, and instead the opposite. So PR, this line over here is your PR complex. Elongated PRs are an indication of heart block because this delay from the electrical conduction is causing your ECG PR complex to be longer and longer and longer. Then your QRS, which we mostly all know about. And then ST. So that ST segment should always be flat, which is really important when you look at ECGs, because in MI, an ST elevation MI, this line here will be raised, and we'll look at a few examples. And then in terms of context of the cardiac cycles, so as we said, when the atria are contracting, that's your P wave. So atrial depolarization, atria contracting, P wave. Then we've got ventricle contracting, so ventricular systole, which is your QRS. And then when they're both repolarized and relaxing and not contracting, we have your T wave. Okay, so looking at the leads of an ECG helps to try and visualize it and see that which leads correspond to which area of the heart, and then consequently correspond to which arteries that are supplying it. Because quite commonly, past medicine, for example, and med school finals will ask, ECG shows ST elevation in this lead, what part of the heart is affected and which artery supplies it. So this diagram here is quite helpful to see which leads are affecting which part of the heart and then correspond to which artery. So leads 2, as you can see, 2, 3, and AVF around this bottom correspond to the inferior aspect of the heart. Then we have your lateral leads, which are 1, AVL, and V5, V6, these guys. So these leads are your lateral leads. And then your anterior leads, so this part of the heart, the anterior part of the heart, are your V3 and V4. So if you visualize it, it makes things easier. It makes sense. Now, a couple examples of ST elevation. So down here in the bottom, I've shown you what a normal ECG waveform looks like, and then we've got one comparing it to ST elevation. So can anyone try and see what leads have ST elevation in them on this ECG? Where can you see it? So Marge says inferiorly, which is correct, yes. So if I can convince you that there's some in leads 2 over here and leads 3 over here, as well as some in AVF. So our inferior leads, really good. And then over here in this ECG, where's the ST elevation? Anteroseptal. Amazing, well done. So if I can convince you, here, here, here. So leads V1, V2, V3. Now, questions as promised. A 77-year-old man is admitted to the CAU with ongoing chest pain radiating to his left shoulder. An ECG is performed, which shows ST elevation in leads V5 and V6. Given the finding, which vessel do you think is most likely affected? So let's break it down. Leads V5 and V6, if you remember the placements of your ECG leads, are quite lateral. Has anybody answered? Oh, no, not yet. Yeah, so leads V5 and V6 are on your lateral chest wall. And if you think about the artery supplying the lateral part of the heart on the left-hand side, do we remember? Does anybody remember? Yes, Pragnya, exactly. Oh, we've got a bit of a conflicting audience here. So I can see why you'd say left anterior descending, Marsh. but actually it's your circumflex. Because think of, let's go back to the, oh, it's going to take me a while to go back to that, isn't it? But let's try anyways. Back to this diagram of, sorry guys, let's use this. So if we say this is your left coronary artery, your left anterior descending, yes, it kind of provides the lateral aspect of the heart, but actually it's more so just the anterior, and the circumflex comes round and is supplying the area which covers leads V5 and V6. So good on you for still recognizing that it's the left side, but actually it's the circumflex. PQRST. Here we go. Just extra revision for you guys. Circumflex artery, here we are. No worries. We've got another question. A 60-year-old man presents with tight central chest pain radiating to his left shoulder. This is his initial ECG. What is your diagnosis? It's a bit of a tricky ECG, I'll give you that one. But if you just look for ST elevation, don't get bogged down by the sort of weird waveforms in the other leads. Anterior semi, yep, exactly. I'd say that's half of the diagnosis. So ST elevations in leads V2 to V6. So if I tell you that, can we modify around? Yeah, exactly. So it's also in the septal leads. So it's anteroseptal. Oh, anterolateral. Let's go clarify that. V2, V3, V4, V5, and V6. Let's look at the diagram again. V2, V3, V4, V5, and V6. So anteroseptal, I'd usually say V2 and V3. And because, yes, actually, it goes all the way around V4, V5, V6. So anterolateral. And in that, when you say antero, usually it also means septal. So antero/septal plus lateral. Does that make sense? I'm sorry for the confusion there. Maj, does that make a bit more sense for you? Because I think I may have confused you there. So V2, V3 are mainly anteroseptal leads, and then your V4, V5, V6 come around the end, anterolateral. Now for the interesting part, the spotter exam. So I've got some anatomy pictures, sorry, cadaveric pictures to practice your anatomy and some radiology as well. Please try and engage with the questions. That's going to make it the most helpful and the most useful for you guys. So, question 1, which other vessels come off from this vessel? First of all, let's identify what it is. So looking at it from this view, if you imagine the blood's coming down your left atrium, left ventricle coming up into this vessel. Any answers? Brachiocephalic, so not quite Pragna, but good thought. So if we look at where this is coming off of the heart, it's your pulmonary trunk. So it's your left and right pulmonary arteries coming out of the heart on this side. Oh, Varun, I can see, I can see why you think it might be a coronary artery, but actually that's a big chunky one. And your coronaries, as you'll see later in some of the other questions, are much, much thinner, much, much smaller. So this first label is your pulmonary trunk. Which other vessels come off it is your left and right pulmonary arteries. Oh, and I've just answered the second question for you. So this is your aorta on the other side, carrying oxygenated blood. So pulmonary trunk on this side and your aorta on the other side, carrying oxygenated blood. Then we've got a CT PA over here. From which ventricle does this vessel originate? So this is again your pulmonary trunk. Which ventricle does this vessel originate from? Right. Oh, hang on, I'm having to think myself now. Right pulmonary arteries. Yes, that's right. Exactly. All right. Oh, Zara says left. I think we've got a bit of a confusion here. Zara, what's the confusion? No, we'll come back to this at the end. But let's continue at the moment. Just in the interest of time. What time is it? Question number 3. What is the outermost layer of the heart called? We covered this at the start. Pericardium, exactly. You've got your pericardium. And between which layers can blood accumulate to cause a cardiac tamponade? So within that's a good thought, Marge, the pericardium and the myocardium. Good thought, but actually it's between your 2 layers of the pericardial sac. So you've got a visceral layer and a parietal layer, and blood can accumulate between them 2. So it's actually separate from the myocardium. Yes, exactly, Varun, in the pericardial sac. So which layer makes up the lining of the ventricles? We spoke about this as well earlier. Can you remember? You've got your pericardium, then your myocardium, and then your endocardium, of course. Yes. Well done. Endocardium. Now, which 2 parts of the heart does this valve connect? The first question. What do we think? This is difficult because you're looking at it from an anterior perspective. So if you're confused as to which vessel's which, look at the thickness. Which 2 parts of the heart does this valve connect? So before we go on to that part of the question, let's keep it simple. What vessel is that? The bigger vessel coming out of the heart. Stronger, thicker, bigger. What do you think it's going to be?
Aorta.
Yeah, exactly. Oh, well done for turning your mic off. It's the aorta, exactly. So which 2 parts of the heart does this valve connect? Or which part of the heart does the aorta come off of?
Left ventricle.
Yes. So the left ventricle and the aorta is what your aortic valve comes off of. And now, unfortunately, because of the animation, I've just answered the second question for y'all. This vessel, the pulmonary trunk essentially, carries deoxygenated blood. So your aorta is carrying the oxygenated blood out of the heart to the rest of the body, and then your pulmonary is carrying deoxygenated blood to the lungs. Okay, now, Varun, earlier you were saying the coronary arteries, but if you see here, can you see the very distinct difference in size between your pulmonaries, your aorta, and then your coronary arteries? So your pulmonary trunk and your aorta are massive in comparison. So if we assume, or not assume actually, we know this is the anterior aspect. You're looking at this heart anteriorly. Which vessel is this? And what two branches come off of this artery? So we know it's a coronary, looking at the size of it. It's much smaller and it's coming on the surface of the heart. Any takers? Left anterior descending and left circumflex. Exactly. So this is your left coronary artery coming down, 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 down. And here we have the bifurcation. So you've got your left circumflex going that way, and you've got your left anterior descending coming down. And actually, I was pointing to this being the left circumflex, but that's not it. It's this coming off this way, if you see. Straight off this left coronary artery coming down all the way there is your circumflex, and this is your left anterior descending. And then secondly, an ischemic thrombus in this artery over here would cause ST elevation in which leads? So this is your right coronary artery. Which leads would it cause ST elevation in? Think of the parts of the heart that it supplies. So looking here, you can see it comes down and it's mainly supplying the inferior aspects. So which leads would that correspond to? Leads 2, 3, and AVF. She's on a roll. Leads 2 and 3, because your right coronary artery supplies the inferior surface. And AVF, you're right. In terms of that, very well done, Marge. Okay, now a radiology question. We're almost done, guys. Well done for getting this far. Question 1, what is the name of this valve that it's pointing to, coming off into that big chunky aorta? And is it tricuspid or is it bicuspid? So the image actually kind of shows you quite well whether it's tricuspid or bicuspid. Aortic valve, and it's tricuspid, exactly. So number 3, how does this chamber differ from its counterpart? So this is your left ventricle that pumps blood up into the aorta. How does it differ from the right ventricle?
Well, it's thicker.
Yes, exactly. So the walls are thicker, the muscle is stronger. Very good, Zara, that's right. The muscle is stronger, the wall is thicker, and the chamber is actually bigger as well. If you look at the previous images, it's bigger than the right ventricle. You can't really see it here, but I'm gonna have to just take my word for it, guys. Aortic valve, tricuspid, and your left ventricle, slightly bigger with thicker walls and stronger musculature than the right. All right, name this artery and its branches. I think we can make a logical conclusion that we previously spoke about the left coronary artery coming on this side, splitting into your LAD and your circumflex. So this would logically be your right coronary artery. And what are its branches? One of them is already labeled, but let's see if you can remember the other one.
Posterior descending.
Is it posterior descending? So it does start with a P, but it's proximal descending. Well done, Varun, though. Good job. And which node does this artery supply? Sinoatrial, very good, Marge. It's a bit of a trick question, actually, because it supplies both. Supplies the SA node and the AV node. Because if you think about it, both are on the right side, and specifically the right atrium. So they're both on the right, and they're both supplied by the right coronary artery. So if you have a blockage in your right coronary, if you've got an MI of the right coronary artery, that can knock out both your nodes and cause you to go into a pretty nasty arrhythmia. So that right coronary, although it's not as commonly spoken about, is quite important. Now this is the arch of the aorta here in an MRI of the heart and its vessels. Do you remember what this artery is? And can you name any of its branches? Well, there's only two branches actually, but can you name them? So it's the first vessel.
Brachiocephalic.
Brachiocephalic, exactly, Varun and Anisha, well done. And what are its branches?
Right carotid and right subclavian.
Exactly. So you've got your brachiocephalic trunk coming out to split into your right subclavian and your right common carotid. And then this artery here, what do we think this is? This is a tricky question. Don't get fooled. Don't be fooled. I guess me saying that would put you off answering, wouldn't it? So your Marge, I can see why you'd think it's the left common carotid, but if you remember, the left common carotid comes off the aorta directly. We spoke about this. So on the right-hand side, they come off the brachiocephalic trunk. So the brachio comes up into the right subclavian and right common carotid. But the left common carotid and the left subclavian comes straight off of the aorta. So this artery here is actually a different artery entirely. Any thoughts?
Is that the left vertebral?
Exactly. Who's that?
Oh, Varun.
Varun, well done. Yes, it's your left vertebral artery, which supplies the spine and the brain. So your vertebra and the brain. And this can be occluded sometimes when people tilt their head back. You can occlude your vertebral artery quite easily. And go into a syncope episode. So if you're lying down in a bathtub, for example, that's a common question, actually. I had it in my finals, that a patient was lying down in the bathtub for a long time with the head back, relaxing, and then they passed out. And that's because they were occluding their vertebral artery. So they were minimizing the supply of blood to their brain and then passed out. So left vertebral artery, well done. Last question, kind of tricky actually. So we'll finish on a good note if someone can get this right. I'll be really impressed. It's chest radiograph, obviously. It's an AP film, but you can still see that the heart's quite big. The patient has a loud S1 and a mid-diastolic murmur. What is your differential diagnosis?
Mitral stenosis.
Well done, Varun. Did I oversell that as a really hard question, but actually it was really easy. So mitral stenosis, exactly. And you can see that on a chest radiograph as a really big heart. So cardiomegaly. And that's because the left ventricle is having to work really hard to pump the blood out. So it's going to become bigger and bigger and bigger, and you're going to get left ventricular hypertrophy and left-sided failure. So your heart's going to be really good, but not your heart's going to be really good. Your heart's going to be really big, but quite inefficient. So you might also see a patient with edema and breathlessness because their heart isn't pumping correctly. So heart failure, essentially. Okay.